Hello, everybody. Thanks, Dana. So Sheldon, or he preferred to be called Shelley, Naiman, and Linda Vickars. This is a husband and wife team of hematologists who individually and as a couple dedicated their lives to improving clinical care for people with bleeding and blood clotting disorders in British Columbia. Shelley was born and bred in Toronto, moved to UCLA for his hematology training, and was recruited to Vancouver, where he was the founding head of the Division of Clinical Hematology in the Department of Medicine. He also established the Bone Marrow Transplant Center at Vancouver General Hospital and later became the hematology head of the laboratory at St. Paul's Hospital. Linda Vickars was a native British Columbian, a passionate clinician. She oversaw the establishment of provincial programs in hemophilia, hemoglobinopathy, and hemosiderosis at St. Paul's Hospital. Both were well known throughout Canada and beyond. They were fabulous clinicians, superb teachers with an innate curiosity. Tragically, both fell ill all too early in their lives, but they were generous, they left a legacy, and we at the CBR honor them each year with a professorship in their name in benign hematology. I can think of no more appropriate awardee than Dr. Victor Blanchette. Victor is a professor of pediatrics at the University of Toronto, a staff pediatric hematologist in the Division of Hematology Oncology, and a senior associate scientist emeritus in the Research Institute at the Hospital for Sick Children. He is also the McCaig-McGee Family Medical Director of the Sick Kids Caribbean Cancer and Blood Disorders Initiative in the Center for Global Child Health at the Hospital for Sick Children. After completing his medical training at the University of Cambridge and at St. Bart's Hospital at the UK, Victor pursued subspecialty training in pediatrics at Johns Hopkins Hospital in Baltimore, followed by fellowship training in pediatric hematology oncology at McMaster University. Victor's research interests are in the area of congenital and acquired bleeding disorders of children. He is co-director of the Pediatric Comprehensive Care Hemophilia Program at Hospital for Sick Children and chair of the International Prophylaxis Study Group. He is a recipient of numerous Lifetime Achievement Awards from all of the leading pediatric and hematology organizations in Canada and throughout the world. I lost my place. Dr. Blanchette, there's so many awards, and I'm just sort of skipping through the awards. Dr. Blanchette is an elected fellow of the Royal College of Physicians and Surgeons of the United Kingdom, and in 2018, he was awarded the Order of Barbados, the country of his birth, for his contributions to the field of medicine. I'm really pleased to invite Victor to give the Sheldon, Naiman, and Linda Vickars Visiting Professorship in Benign Hematology lecture this year. Victor, wherever you are, I welcome you. Oh, there you are. Hi, Victor.
So, good afternoon, everyone. And Ed, thank you for those nice remarks. It truly is my honor to deliver this lecture to you as part of the 15th Earl Davie Symposium. And Ed explained I grew up in a little island called Barbados in the Caribbean. Some of you may know that, just 300,000 people. But then my journey, as he explained, and my career has really been in pediatric hematology at the Hospital for Sick Children in downtown Toronto. It's focused on the acquired and inherited bleeding, clotting disorders in children under age 18. We follow approximately 200 boys with this disorder, hemophilia. And it was my privilege to meet and work with Linda Vickars when she was heading the hemophilia program in Vancouver. And to be named to give a lecture in her award and Shelley Naiman is truly, truly a great honor. And I thank the organizers. Now, my topic is From Royal Genes to Cure of Persons with Hemophilia, a Dream Almost Fulfilled. I'm going to try to cover about 75 years worth of experience in about 30 minutes. Almost impossible, but here we go. These are my disclosures. Well, I start with this publication in New England Journal of Medicine in about 2001. It was authored by Pierre Minucci, a giant in the field of hemophilia. In Milan, Italy, he led one of the famous centers there. And Ed Tunningham from the UK, a giant in gene therapy. And the title is, as you see, The Hemophilias, from Royal Genes to Gene Therapy. Remember, 2001. And here is the family pedigree of this famous queen, Queen Victoria, a formidable woman. And she was a carrier of the hemophilia gene. In this slide, the circles are females, and those that are with red, half circle, are carriers of the gene for hemophilia. And her youngest son, Leopold, male shown in the squares, was affected. Leopold died following a head injury in France. He was about 30 years of age. And in this publication in 2001, here's what was written by Pierre Minucci. Hindsight in life, as you know, is everything. Since the two X-linked hemophilias, that is factor VIII and factor IX, hemophilia A and B, are clinically indistinguishable, and none of the descendants of Queen Victoria, who were known to be affected, are alive. The last one, Waldemar, died in 1945. We may never know which type of hemophilia they had in this family. Well, that's false, because some years ago, with exhuming and getting the DNA from one of the pedigree, and it was published, it was made clear that Queen Victoria didn't actually pass on hemophilia A, the more common one, but they had hemophilia B, factor IX. And at the end of that publication, this was a statement. We can confidently predict that the new millennium will see an end to this ancient scourge, hemophilia, a disease that has been described and was apparent for hundreds of years. We will see, and hopefully I can tell you that we're near to that. Just a few words about the hemophilias. As I explained, these are mutations in the genes for factor VIII, hemophilia A, the larger gene, or for factor IX, hemophilia B. Approximately 1 per 5,000 live male births, and it's across all ethnic origins, will have hemophilia A of some type, and a smaller number, about 1 per 30,000, so there are about 5 or 6 hemophilia A patients to every hemophilia B factor IX. Importantly, about a third of patients, there is no family history, although when you go back, you can usually discern that somewhere in the lineage, it's a grandfather, because this is a sex-linked disorder that is manifested in males almost exclusively, and it's the females who are carriers. Now, these labile coagulation proteins, factor VIII and factor IX, when injected, and they have to be injected, are having half-lives of about 12 hours for hemophilia A, factor VIII, and just double for factor IX. Well, 1964, Earl Davie published a seminal paper in Science, the Waterfall sequence for intrinsic blood clotting. He was a giant in the field of hemostasis. And here with Dr. Oscar Ratnoff, he described what the Waterfall sequence for intrinsic blood clotting. You know, that was 1964, some 60 years ago. And now, this is like for the teachers of biochemistry, we know the hemostatic orchestra is very complicated. And this is a simplified version of it. We know that clotting is triggered at the sites of vessel injury by activated factor 7A and tissue factor, generating a bit of thrombin and then back activating through this cascade system. The formation of fibrin stabilized, and then you get the clot, which is a platelet fibrin clot. It's localized, and you can see in the circle where factor IX and factor VIII are. And factor VIII, its function is to bring together activated factor IX and factor X on a negatively charged phospholipid surface, the activated platelets, to generate thrombin, which converts fibrinogen to fibrin, which is then stabilized. And there are procoagulant and anticoagulant And that would be a total different lecture, although we will touch on that in this talk. Here is a time-honored classification of the hemophilias. In health, we have approximately 100% of activity in a functional assay in a coagulation laboratory of factor 8 or 9. Persons with hemophilia have a reduced level below 40%, and if you are severe, it's 1% or less, just below. And this is a group that have the frequent spontaneous bleeding, the hallmark being bleeding into muscles and joints, and they're the large joints, not like rheumatoid arthritis. They tend to be ankles, knees, and elbows, the target joints, but occasionally and devastatingly, hips and shoulders. If you've got a bit of factor 8 or 9, you're moderate, 1 to 5%, and you bleed but less. And if you're mild, above 5%, and certainly, as I'll show you, somewhere in that 10 to 15% range, you only bleed generally with provocation if you're going to do surgery or traumatic injury, and they often are diagnosed later in life. Now, if you go to the street and you ask the layperson about hemophilia, they have this concept that a little cut, you bleed to death. Of course, incorrect. Bleeding does stop, but it's delayed. And the characteristic pattern of bleeding is not immediately joined. In fact, in the newborn period, it is often, tragically, a baby, maybe if there's no family history with an instrumental delivery, it could be a devastating bleed in the head. Or more likely, when you're doing the heel prick, prolonged bleeding, or in males, of course, with circumcision. Not an uncommon story. In that first 6 months of life, babies do very little. And in fact, what you tend to see is bruising, or as the kids get around 6 months, they're putting sharp things in the mouth. So you get mucosal bleeds, frenulum bleeds. And it's only around about 18 months, 1 to 2 years is a typical story that you get this spontaneous bleeding into the ankles, knees, or elbows, and it's painful, swollen, and that can trigger the diagnosis. Now, here's a picture. I'd like you to remember this. This is a little boy from our clinic with hemophilia and difficulty getting blood, and look at the bruising and that swelling. In fact, you can get compartment bleeding, the squeezing of nerves with devastating consequences. And this was a boy with hemophilia. Giving the needles and giving them frequently is a tremendous burden in the pediatric age range. Now, this is an aspirational slide. It's by Mark Skinner. He himself has hemophilia, and it captures the 75 years of hemophilia. 1940s, 1950s, you had severe hemophilia. You didn't move from near to a hospital. You depended on fresh frozen plasma, or in the mid-60s, cryoprecipitate, and no ability to travel, and a short lifespan. Many of these patients died by age 20 or 30 because of some bleeding after an injury or surgery. And it was only later with the replacement products, initially fresh frozen plasma, but mid-60s, late 60s, the commercial companies using plasma. And now we're talking about 10 to 20,000 donations going into a single batch, could make easy to use lyophilized factor 8 and 9, could be stored in a refrigerator, infused by the patient, and they could travel. It was mind-blowing. And then that led to the comprehensive care teams, the ability to go on vacation, to travel, and ultimately now almost a normal lifespan you see up in the top with gene therapy. I'm going to show you a case. This is a boy from Trinidad, a little island near to Barbados, 1.4 million people. He was born, he was diagnosed with severe hemophilia B, less than 1%. He had multiple bleeding into joints with severe arthropathy. When he was about 10 years old, his father moved with him to Canada. They became citizens. And this is how he looked. He could not straighten that leg, quite dramatic. Or orthopedic pediatric surgeons did major operations. They realigned him. He was able to use safe blood products, infuse them himself a couple of times a week. And I'm going to tell you his story later. He is now 23 years of age. But this is what untreated or poorly treated hemophilia is like. And that's 80% of hemophiliacs in the world that get no access or limited access. And the thing is that you must give back this factor 8 or 9 intravenously. Shown here in a cartoon is you take the factor, you infuse it, up goes the factor VIII level. You get about a 2% increase for every unit of factor VIII, about 1% for factor IX. And the little picture there showing a boy self-infusing. Most of our boys with severe hemophilia are actually the parents when they're younger, or the boys are giving the product at home. We see them every 6 months. This is true of your pediatric clinics in Vancouver, a large a program now headed by Mark Belcheruti. And then he delivers at age 18, hopefully good products to the adult clinic where Linda was. And now, of course, you have a big team at St. Paul's. Now, the world is a roller coaster ride. So I told you that in the 40s, 50s, really devastating. And then along comes cryoprecipitate, the first concentrate of factor VIII, but then these lyophilized concentrates in the 70s. But they were potent transmitters of hepatitis and AIDS. And we didn't know that till the 1980s. So going from a high in the 70s, the AIDS devastation, that epidemic, I'm going to show you the Canadian data. And then because of the cloning of the genes, safe recombinant products, now designer products, and even non-factor products. A true roller coaster ride. Look at the data for Canada. In Canada, we didn't have a fractionation plant. Hemophiliacs were dependent on commercially obtained 8 and 9 concentrates, and they transmitted everything that there was to transmit in plasma. If you were above 10 years of age, living in Canada in this era, 80% were HIV infected. 2/3 were hepatitis C co-infected, many with hepatitis B, and AIDS replaced bleeding as a major cause of death in these people. This is data from our registry. Erwin Walker, he headed the program at McMaster. He's a hematologist from Australia. And it really, if you put this in terms, there are about 4,000 persons with hemophilia in Canada. Many of these patients are dead from AIDS and complications. This is way worse than the COVID pandemic in terms of what it did, but it brought us safer products. And of course, you know, there was a commission of inquiry on the blood system, Justice Creaver, that split the Canadian system into Hemo-Quebec and Canadian Blood Services, and books have been written about this. This truly was a disastrous time for persons with inherited bleeding disorders. I'm going to take you back to the beginning of the 60s. Here is another famous person, Professor Inger Marie Nielsen from the Malmo Clinic in Sweden. They had a good healthcare system. She could measure, and her team, factor VIII. They had orthopedic people who could assess joints. She went around the country of Sweden and cataloged from about 7 million people. And what she could tell at that time in the late 50s is that the natural history was severe hemophilia, frequent bleeding, terrible arthritis, poor quality of life. And if you had a little bit, and I focus on the 3%, that mild, much better. And she was very clever, and her team. They reasoned that by just substitution, you could change the severe into moderate, and you would recapitulate that natural history. This is the gold standard Malmo high-dose prophylaxis. And for factor VIII, that meant giving the needles factor VIII 2 to 3 times a week, every other day. 150 infusions. Factor IX, about twice a week. And the goal was at 1% or just above. She took 25 years to report her observational studies. And clearly, she emphasized the need to start at a young age in these boys with severe. If they did that and they were under 2 years, they dropped the bleeding rate from about 1 every week or twice a week to 1 a year. Of course, compliance, and particularly in adolescent, important. And they reasoned that some patients had subclinical bleeding that could not be picked up by either the patient or the family in a young boy. They were right, but they didn't prove it. That was later. And there was never a level 1 study. So Marilyn Manco-Johnson and her team in Colorado and a number of sites in the US did this classic randomized 2-arm study published in New England Journal of Medicine in 2007. They took boys with severe hemophilia A who did not have antibodies to factor VIII, who had very little bleeding and no joint perturbation, and they randomized them between on-demand or episodic treatment, treat only for a bleed, versus preventative prophylaxis using the Malmo regimen. Any bleeds during that 5-year trial were treated immediately with at least 3 doses, And importantly, they did MRI studies of those joints. They had to sedate the boys at the beginning and end of the study. And their results were predictable but dramatic. So by MRI, which is exquisitely sensitive, looking at joints with no cartilage or bone changes, prophylaxis or preventive treatment was superbly better than episodic on-demand therapy, with an 84% relative risk reduction. And you see that bleed rate spontaneous 0.2 versus 4.4 in the episodic treatment. Highly significant. This is level 1 evidence. It established prophylaxis as the way to go. And that was now endorsed by the World Federation of Hemophilia. In Canada, at the same time, in 1997, we started a parallel study with the identical inclusion-exclusion criteria. 56 boys from 11 pediatric sites across the country were entered in this long-term, and I stress long-term, because you have to have that to see the joint disease. And the median follow-up was 10 years, with boys out as long as 16 years. The model for this study, and I have to give him credit, was my dear friend, and you know him, George Rivard, for instance, Justine. And he was worried about ports for venous access in these little boys. And he said, look, Victor, you should just give the therapy once a week. You can see here, this is a Canadian style, once a week. And if they bled with frequent bleeding, we went to twice a week, and then the full dose prevention, Malmo. Now, this is a definition of target bleed. That is 3 bleeds into any of those joints, ankle, knees, elbows, in a 3-month period. We would never allow that amount of bleeding now. But hindsight again, this was 97. We were able to carry the study through for a median of 10 years. We did MRIs, not at the beginning, but midpoint and at the end, and we found this results. Bleeding rate about 1 a year, spontaneous. We had excellent overall for the group. Joint outcomes measured by either physical exam, the joint scores, the Hemophilia Joint Health Score, or by plain radiographs scored with the Pedersen score, and by MRI. But that was not true for every joint, for every boy. Importantly, we documented that a third of joints with no history of bleeds by MRI had the telltale message of bleeding. And here is a boy, 10 years, severe hemophilia in that study, never reported a bleed in his ankle. And look at the MRI. You got synovial proliferation with the inflammation. You got hemosiderin, the marker of iron, and effusion. This boy clearly had bleeding. So if you don't look, it's not just the history, the bleeds. You have to look with ultrasound and other technologies which we use now. Now, I said 80% of people in the world with hemophilia either don't get diagnosed or have limited access, but a number of countries, and they're listed here, China, India, Indonesia, Tunisia, have started with programs of low-dose prophylaxis, preventive treatment from a young age, using 10 to 15, not 30 IU per kilogram, twice a week. And they can show in these studies published a dramatic decrease in bleeds, a decrease in hospitalization. The boys are able to go to school, they're more physically active, and the improvement in joint scores. Prophylaxis is standard of care, but very expensive. I return to the genes. The genes factor 8 and 9 cloned in the 1980s. This is just factor 8 and factor 9. You're very familiar with this. And that led really to where we are now with this plethora of products. We no longer have unsafe products. We have virus inactivated plasma-derived 8 or 9 concentrates. We have recombinant safe concentrates. And now we have bioengineered extended half-life products. I'll speak to that. And importantly, even non-factor products. I'm going to speak about one of them, the bispecific human monoclonal antibody that was discovered by the Japanese 10 years ago and really revolutionized treatment for those with inhibitors. But playing with the other system, either antithrombin knockdown or anti-tissue factor pathway inhibitor, this is really using the coagulation cascade now to increase the prothrombotic axis. Very good data on some products in late clinical stage. And of course, the gold, gene therapy and cure. Here are the products. These engineered extended half-life factor 8 concentrates on the backbone of recombinant factor 8 or 9. There are 4 factor 8s, 3 factor 9s in the world by the different manufacturers. The technology is to fuse the factor with either IgG or albumin, or to pegylate the products. So the pegylation at different sizes protects the elimination. You can increase the factor VIII half-life about 1.5-fold for factor VIII to about 18 hours, and 3 to 5-fold for factor IX. So instead of giving the standard half-life twice a week, once every 2 weeks, and you get the same results. Factor VIII, you can go down from 3 needles a week to 2 needles a week. That doesn't seem like a lot, but think of it, that's 50 needles a week. And remember that picture of that little boy. If you were a parent and I told you you could save 50 needles, you would be begging me to give you these products. But they're expensive, and unfortunately, some of the funders think this is just convenience. This is not really impactful, but we have to fight for it. Now, another breakthrough, you know, the dance partner, factor VIII, von Willebrand factor, very tight. That's what limits the half-life of factor VIII. And one company recently, they've been able to break that ceiling, and now they have a product that is just about, it's an advanced clinical trial in children. It will have a 36-hour approximate half-life, double the half-life of factor VIII, allowing once weekly dosing. And this product, I talked about it, is a bispecific antibody engineered by Chugai scientists. So it's very clever. It brings together factor VIII to factor 10 and essentially mimics factor VIII. The key here is subcutaneous. You can give this product once a week, once every 2 weeks, once a month, and you can get bleed rates down to 1 spontaneous bleed joint bleed a year. The trials are finished. The product is commercialized. They've been using it in the USA for almost 2 years, and I'm proud to say that in Canada, we now have it for both inhibitor positive and just recently for inhibitor negative. We're going to be putting a lot of our boys now on this product sub-Q, a bit like diabetes cure, and they're not even getting factor VIII. They're getting a mimic for factor VIII. This is revolutionary. And here, back to the PK curve, you can see the factor VIII, using that as an example. The way forward is personalized, individualized preventive therapy, prophylaxis. So if you give a big dose, you get up to 100%, the peak's what you need for surgery. But I draw your attention to the little cartoon. And you know, in Vancouver, you've got those beautiful mountains. And there are hemophiliacs that ski, you know, collision type sport. You can get injuries. What level do you need? And of course, in the young guys, soccer. And that may be where we're getting some damage with subclinical bleeding. And that's why we see ankles still as a problem. So we got to think about troughs, that protective level. And emicizumab, the subcutaneous molecule, gives you, you can't measure it, but it seems to give you a protective level somewhere between 15 and 25%. With this product, you're essentially converting severe hemophilia A, it's not for B patients, into mild hemophilia A patients. But of course, if they now go and do high-risk activities, not going to be enough. And that really speaks to this historic data from another great hemophilia clinic in the Netherlands, the Van Cruyffel Clinic, where they looked at retrospectively about 400 patients. They could show the number of these joint bleeds was much higher, severe, under 1%. When you got to 3%, the same thing we were told by the Malmo Clinic, things are better. And out at 10 or 15%, you probably are not bleeding much unless you get an injury or you have to go to surgery. So all of this pointing to what levels you need. We can now measure using a pharmacokinetic population PK basis, and the PKs vary. It's very individual dependent. For factor VIII, there's a 2 to 3-fold difference between the same individuals with less than 1%. And here, with using no washout, patients on prophylaxis, we get them to get an infusion at home, a regular prophy dose, know the amount, the time they come to the clinic, say 24 hours later, we get a blood sample, we give them another infusion. 3 hours later, after seeing the team, another infusion, put it into the population PK program with Bayesian forecasting, and you get a very nice readout of clearance, half-life, time to 1 or 3%. Very, very practical. And there are 2 systems. One is for the Takeda products now, Advate and the Dynavate, but Alfonso Iori at MAC with the Waterloo people have it for a number of people. It's a WALP system. And now the devices, people are using these now with something akin to a hand phone where you can, it's like a factor meter, the idea that you can, at any time, if you've got this profile of yourself, you'll know roughly what level you're at based on what your frequency and amount. And then you can use that really to think about safe levels, be in contact with your comprehensive care team. We don't know the exact levels that are safe. We know from surgery, there are a couple of reviews suggesting that for collision type sports or high risk competitive sports, you need somewhere in that 40 to 60%. But certainly it's not going to be protected at that level, just at 10%. So the real issue with emicizumab is you don't get the peaks. So what are you going to do if you're going into surgery or you're going into bigger activities? And of course, an activity is not an activity. I'm sorry about that. Here, look at skating, all the same activity, but the little boy padded up, the Rideau Canal, you know, the longest freestanding, but the ice there is very rough, so you can twist ankles, a skater with jumping, and of course, the famous Canadian sport. So we do have boys that participate in hockey. All of this needs to be given in the context of a comprehensive care team. You have it in Vancouver Pediatric Center, the Adult Center, we have it across the country. Right at the center should be the patient, the family, if it's a young boy, a physician or physicians, nurse coordinator, laboratory, social worker, occupational therapist, and look at the flanks. Now we have patients, we have geriatric hemophilia with a better quality of life and age. So we're really in a different era. And now musculoskeletal, maybe sports medicine therapists. So we need this comprehensive team with all these new products to be able to get the best outcomes, and all done in a shared decision-making model with the patient or the family for the child at the center, and then iteratively, benefits, risk, alternatives. What can we give you? What's your lifestyle? Picking what is right for that age. Now, the World Health Organization describes quality of life as an individual, very individual perceptions of their positions in life in the context of the culture, the value systems in which they live in relation to their goals, expectations, standards, and concerns. Very age dependent, culturally dependent. We have a chocolate tool questionnaire, 35 questions, 0 to 100. 100 is best, 0 is worst. Nobody gets that. If you go to the countries with access to product, Europe, North America, you get high 70s, 80s. Get out into countries like Jamaica, where they just have plasma, cryo, a little donated product, or Ivory Coast, way down. And I use this as a thermometer of well-being. Back to our case. So this young man comes orthopedically, we put him back together. He's at sick kids, he's getting that extended half-life product and doing very well with minimal bleeds. And then he strikes gold. He was able to be enrolled in a gene therapy trial, factor 9. He's now followed at St. Michael's Hospital. He's a carpenter. He's at 10% level. He's not bled for 2 years. He's never infused factor 9. And I talked to him recently. I mean, this is as good as you can get, but very expensive and not yet commercialized. There's a lot of work going on to optimize gene therapy. These are prototypic diseases, factor 8 and 9. The type of transgene, a lot of the trials now are using the Padua variant of factor 9. That's a gain of function, the different cell lines, and mostly it's adeno-associated virus that's packaging the genes. And many people have coexisting antibodies to that. But we now know that with some of the serotypes, you can actually still give successful gene therapy. Some of the gene therapy is associated afterwards with a transient cellular immune response, transient transaminitis, but better understanding of that is needed. And of course, the durability of expression. For factor 9, it looks pretty good out now at about 10 years. That was what started, a smaller molecule. Factor 8, still questions, but I think the technology will get us there. Every bleed matters to hemophiliac. You've got to recognize it early, treat it well, treat it to resolution, particular muscle bleeds with musculoskeletal, aiming for excellent joint health, excellent quality of life like the peers. And here, this is a bionic man, but DNA. You know, I was in a conference a couple of weeks ago. There was a hemophiliac talking. He just completed an Ironman. He was a severe hemophiliac. That could never have happened in the 60s or 70s. We've come a long, long way. So I think their speculation that we're eliminating the scourge is actually correct, but expensive, and we have to monitor. You can't do serial MRIs, but I think ultrasound now is the way to go. It's very good for picking up soft tissue. Point of care ultrasound, people are looking at augmented intelligence and sharing images back from remote centers to the team at this. And I think the virtual world is opening up a lot of this. So really a lot of excitement in the hemophilia world and inherited bleeding disorders. It's been part of my life for 30 years. I hope that I've convinced you that, you know, things are really brighter. I'm showing Vancouver. I always say Vancouver is my favorite, one of my favorite cities on when there's a blue sky. It's one of the most gorgeous cities in the world. We're not too bad in Toronto, but, you know, not like Vancouver. I hope Linda would have been happy with what I said. She and Shelley were great, great Canadian icons. And of course, Earl Davie, I thank you for your attention.
Thank you very much, Victor. It's Dana. I think we have time for a couple of questions. So I see that Ed Conway has his hand up already.
That was fantastic. If you were here, you'd see that it's sunny outside. Isn't that true, everybody? Maybe not. I do have a question, and it came up actually at Paul Dean's talk as well, in terms of servicing the underserviced. And I know that your involvement in Barbados is close to your heart. The availability of emicizumab, as an example, to me that would be the treatment of choice for that population where they don't have easy access to intravenous therapies and on a regular basis to other blood products. So what are the chances of the World Health Organization and the World Hemophilia Federation, rather, and the international community supporting the multitudes of hemophiliacs in those situations?
So excellent question, Ed, and I tell you this promise there. So the World Federation of Hemophilia, centered in Montreal, actually has a humanitarian program. A number of the companies, including Roche, are giving product. And I can tell you as we speak, some patients in Jamaica are on emicizumab. Now, if you have inhibitors to factor VIII, and they're high titer and neutralizing, factor VIII doesn't work. That's about the overall incidence of inhibitors, alloantibodies, is about 30% for factor VIII, high titer about 15%, fortunately much less for factor IX. And those patients, they were like old-time hemophilia. Factor VIII doesn't work. You have to use bypassing therapy with recombinant 7/8, well, quite good nowadays, or FIBA, the activated prothrombin. But that's been blown away by emicizumab. Emicizumab is now the standard of care for inhibitor-positive patients. And I think what's going to happen is Novo Nordisk have a similar product in advanced clinical trial. This subcutaneous product is really going to take over. So if you look in the United States now, somewhere around 20 to 50% of severe hemophilia A inhibitor negative are on subQ therapy. We've just started that role here in this country. The prediction is that in Vancouver, 20 or 25% of the families now it's available, and within a month or two, will elect to switch to subQ over IV. And this is absolutely what would be so good in countries that are poor resource, in many parts of the world, the Caribbean, Africa. Of course, hopefully gene therapy as well. The prices are coming down, but it's still expensive. So I think there is a silver lining. I think there is hope, but you need the multidisciplinary teams. And one of the worries is that, the governments are cutting back on that because the patients then can't recognize bleeds and they'll come in late. They don't want to come to the hospital, come down to the Vancouver Big Center. So we're constantly changing, and the virtual technology and communication will be very important.
Is it antigenic in any way or not? Because that would be a theoretical concern.
Is that Cedric? Cedric, I think have I got it right?
That's my unfortunate accent.
Well, anyhow, the answer is, Cedric, that you do make antibodies, but they are relatively infrequent. This is an immunoglobulin, and they seem, at least, we need more data to be not very much influencing in the rare patients it occurs, the clearance of the factor. So it may be 1 or 2 patients, but to a large extent, that has not turned out to be a problem. The problem with emicizumab is really, particularly in those inhibitor, is thrombosis. And of course, anytime you use these medications, or you tip this balance of nature, you can do things. It's that delicate balance between bleeding and clotting, anticoagulant, procoagulant, and we are having to watch that space very carefully.
Victor, it's Ed Prysdale here. How you doing? Thank you so much for joining us today. I'm wondering about factor VIII gene therapy. It's lagging behind factor IX because so far the expression vectors are not giving very high expression. And I'm thinking, are you hearing wind about a long-acting factor VIII being expressed for gene therapy?
Well, no, what I would say is that some of the VIII studies, which are, of course, are not as mature in years as IX, the biomarine studies, and using some of the technologies that I alluded to, are pretty spectacular. In fact, for factor VIII, I mean, the problem there was packaging the factor VIII gene into the vector, right? So it looks like, more and more advances are being made. So the gene factor VIII was put on, not on hold, but they probably will commercialize within a year factor IX. I can't say, but it's close. Factor VIII, there was a worry about the fall off over time. But I think that barrier is also being broken, right? So if you can take, what we do know is that there is, again, interpatient variation. So even with factor IX, which is much more stable, you may have a person who ballparks out at 20% or 10% or 35%. But that's putting you in a very nice spot for very little bleeding. The worry is that the gene therapy studies are in adults. They're now into adolescent. But in young children, because of the worry about integration and the liver size and the drop-off, they're not in pediatrics yet on the 12, right? So, but that's the time when you're getting bleeding and setting up the joint disease. So there is a lot of ground here to be covered. But I will tell you, there's great excitement about both factor VIII and IX, and I think they're going to be in the space. The problem is they're talking about costs, perhaps $1 million to fund a gene therapy of factor VIII or IX. Who's going to pay for that? Well, the government here in this country, and it probably is saving over the long term. They're talking about maybe half up front, and then you pay like your mortgage, depending on your factor level, every so much, the government every few years. I think a lot of those things need to be worked out. But with a lot of these novel therapies, the more competitors in the space, that brings down the price. And I am optimistic when we look at the choices we have now. I mean, really spectacular, and the science is driving it. The long-acting factor VIII, there are going to be, we have more choices now than we ever had before, and that's really good for persons with hemophilia, severe.
Thank you very much.
And thank you, Victor, and congratulations again on being our named professor for the Naiman-Vickars Award this year.
Well, thanks to the organizing committee, and it is a tremendous honor to me because of the person's names who I spoke on behalf of today. So thank you. I apologize I couldn't be with you in person, but greetings to all my good friends out in Vancouver.